Hello, everyone. Welcome back to another Rafael Medina subspecialty episode. My name is Maddie, and I'm facilitating the session today. And I'm so thrilled for today's session because we get to learn hematology, which is the focus of today's session. And we have two phenomenal educators here from Dana-Farber, Mass General Brigham Hospital. Our case presenter is Dr. Andrew Song, who is a hematology fellow at Dana-Farber. And we have Dr. Arielle Langer, who is a hematologist also at Dana-Farber, who will be teaching us today. So I know it's late on the East Coast, and I really appreciate both of you for taking time out of your days to teach the session. So I'm going to pass the mic first to you, Andrew, and would love to hear a little bit about kind of what drove you to hematology, how you developed an interest in it, and if you have a specific interest within hematology.
So let's see. So my name is Andrew. I'm a second-year fellow in our fellowship here. So it's a program for adult hematology. This is the first year where the American Society of Hematology has this new program where you can get much more focused hematology training during fellowship. It's called the HFFTP, or Hematology Focused Fellowship Training Program. So I was one of the guinea pigs for that, and I am now in my second year of fellowship. I won't comment on my specific interests for the purposes of the listeners on here, in case that's any spoilers at all. But otherwise, I did my training and residency at Mass General Hospital, so it's stuck around here in Boston. And yeah, looking forward to discussing today.
Awesome. Thank you so
Oh,
much.
and you asked me why I got interested in hematology. That's kind of
Oh,
interesting.
yeah.
I think it was, I had a fantastic mentor who got me early, and, midway through medical school. And I think hematology is a really nice intersectional specialty. We have a lot of cool, fun, rare disorders within our own realm, but we're always working together with other specialists and primary teams across the hospital and the outpatient setting. So it's incredibly multidisciplinary and very laboratory based as well. So it's always fun to learn about the fun assays.
Amazing. Well, thank you so much for presenting a case today, and we will hear about your specific interest probably by the end of the session. And now I'll pass the mic to you, Dr. Langer, and would love also to hear about how you found yourself in hematology and if you are willing to share a specific interest that you have.
Absolutely. Thank you so much for having me. I think if you go back in time, the very beginnings of my interest in hematology were when I was really interested in blood drives as a volunteer activity all the way back to high school and college. And every step along the way, I became more obsessed with what gets called benign heme or non-malignant heme or classical heme. We don't know what to call ourselves, but we do know what we do. But it really, really consolidated because I love diagnosis, not I also like management, but I like diagnosis the most. I think it's the most fun part of medicine. And in hematology, you really have to be a Sherlock Holmes. There's very few diagnoses that are made by a single test with a binary result. A lot of the time, it's actually a tough call to see if someone's hemolyzing or not, or make an assessment about how to interpret antiphospholipid labs. I have no idea what Andrew's going to present to me today. So I don't know if any of this is an accidental spoiler, but I think that kind of integrative thinking and reasoning really, really appeals to me. And blood smears are pretty, so that also helps a lot. I spend a lot of time at the microscope with great joy. For this purpose. So as far as what I focus on, I run two clinical programs at the Brigham Dana-Farber. Our thalassemia program, which means I take care of a lot of congenital anemias as well as that specific one, and other forms of hemolysis that spill over to it. And then my other passion, which just for anyone listening, you don't have to choose just one thing. You can't choose 60 things, but you can choose a couple things. The other program that I run is what's essentially a women's health and hematology program. It gets called the Women's Bleeding and Clotting Disorders Program. Kind of wordy. I didn't get to name it, but I do get to run it. And so those are kind of the areas that I love the most, but really everything clotting, bleeding, and red blood cells makes me happy.
That's amazing. Well, I think both of your passion is infectious right now, and I'm so excited to learn. So without further ado, let's jump into the case. So Vinny, thank you so much for scribing. You can go ahead and share your screen. And Andrew, whenever you're ready, you can share the first aliquot.
Okay, so The one-liner for this patient's initial presentation is a 37-year-old female with history of ITP or immune thrombocytopenia who presents to the emergency department with malaise, chest pain, and a reticular rash on the legs. So 4 days ago, she was seen in hematology clinic for routine follow-up of her ITP. Her baseline platelet count is 125,000, but had recently dropped to 60 despite a stable dose and adherence to her ITP medication, which is eltrombopag, a thrombopoietin receptor agonist. So the decision was made for her to start receiving rituximab. So she received 1 infusion of this with plans for more. But 2 days later, she presented to the ED with the symptoms that we discussed with malaise, chest pain, and a reticular rash. There were no recent travel, no infectious exposures, no recent procedures, and she's not had any increased bleeding or bruising, either at baseline or during this acute episode. In terms of her past medical history, really just the ITP. She was evaluated by rheumatology for a potential diagnosis of lupus, given some chronic symptoms of fatigue, myalgias, arthralgias, as well as the ITP. And as part of the diagnostic evaluation, she did have some antiphospholipid antibodies sent. And these were notable for, let me know if I need to slow down. I see that the typing is high speed in real time. But the labs were notable for a positive lupus anticoagulant, and cardiolipin IgG of 83 units via an ELISA assay, an IgM of 44 units, and an anti-beta-2 glycoprotein of IgG 94 and IgM of 54. She's currently continuing to be evaluated for a potential diagnosis of lupus. Medication-wise, it's just the eltrombopag, and then no notable family, social, or allergy history.
Thank you so much, Andrew. And Dr. Langer, I know this is quite a lot of information, and there's a lot we could dissect here, but I wanted to ask initially, we learned that this patient has a history of ITP, and I'm curious if you could talk a little bit about that diagnosis in particular, how does one come to a diagnosis of ITP? And before we dive into all the additional details that Andrew gave, would just love to hear your pearls and wisdom on ITP and how one makes that diagnosis.
Yeah, so ITP used to stand for immune thrombocytopenia, but over time we kept the same acronym and started calling it, it used to be called idiopathic, and now we call it immune thrombocytopenia because we realized that it's the immune system's fault. And so one of the tough things with ITP is that it is considered a diagnosis of exclusion, meaning that there's no test that's specific enough to give it to us. Kind of going back to my point about one of the things I love about hematology is that I can't just order a test that says, yes, it's ITP. No, it's not ITP. Having said that, it's often really easy to exclude everything else depending on how the patient presents. So Andrew gave us a snapshot in time of how the patient's doing now. I'm sure that at some point in time, the platelet count was much lower if the patient was started on eltrombopag, because unless someone has a specific reason to have a higher threshold, the goal platelet count is 30. So a lot of patients with even significantly low platelets aren't on treatments. My guess is this patient was much lower than that at some point in time. So when you have a patient present with an isolated super low platelet count, there's not a lot of things on that list, and it can often become pretty quick to exclude everything else. The only way you ever really know something is ITP is when you give them immunosuppression and it gets better, because there's not any other cause of thrombocytopenia that really does that, which is hard when someone presents at a platelet count that's sort of ambiguous. You're not happy when someone's platelet count is 55 to watch them, but we don't really have an excuse to give them immunosuppression. TPO-mimetics or thrombopoietin mimetics, which also get called thrombopoietin receptor agonists, which are this class that eltrombopag comes from, are the one medication that doesn't necessarily confirm the etiology because they are mimicking the growth factor. Other causes of thrombocytopenia will also respond. And so it's not frontline therapy. I'm sure it wasn't the first thing this patient was given, but it's the exception to the rule that treating it will be pretty specific. Having said that, Andrew, I'm curious, did the patient present earlier with a much lower platelet count? Do you remember, or was it you met them too late to know?
Not I think this particular presentation, no substantially lower platelet count at this point in time, but just in prior chart review, there were historical platelet counts in the 20s, some even 10 to 20s or so.
Yeah, and so that's what I mean. When you have an isolated platelet count in that range, the list is pretty short. The list is other stuff like TTP, which is really unlikely if the patient's not anemic, leukemia, meds. So it's really a pretty short list and you can get there pretty quickly. Steroids are frontline therapy to rescue them. IVIG is another frontline option, but commits them to being in the hospital usually, unless you have already a hematologist involved and they can get to infusion center. So it's not surprising to see the patient was maintained on this med. I'll pause there and let you guide me on what you want me to talk about next.
No, that it was really helpful to kind of hear your approach to ITP and how one makes that diagnosis. I would now love, we heard about some of these antiphospholipid antibodies, the positive lupus anticoagulant, anticardiolipin, and would love to learn from you about how you interpret those.
So they were ordered in this setting for kind of two separate reasons. First of all, antiphospholipid antibodies are part of the diagnostic criteria for lupus. So the rheumatologist may have been ordering them for that reason. But the other thing to keep in mind is that for ITP, there's a much higher rate of concurrent antiphospholipid syndrome than there is for antiphospholipid syndrome in general, with or without lupus involved. And so this co-association is really important for two reasons. And you should think about it in both directions. When you have a patient with antiphospholipid syndrome and their platelet count is low, or when you have a patient with ITP, you have to think about this, because one of the times that they're the most likely to clot is when you acutely correct their platelet count, because it sort of was not, we never want to use that as a way to treat, but it just then raises their thrombotic risk. And so this patient had all three assays positive, and I think, Andrew, they were all that two serologies, cardiolipin and beta-2 glycoprotein 1, were both over 40. So
that's
that
correct.
criteria.
And for the IgG specifically.
And for the IgG, which we know is more important than the IgM. The criteria that we don't have, because it may not have been remeasured, or maybe it just wasn't the time point, is were they persistent? Because one of the things that we always want to do with antiphospholipid really steps back to saying, why are these tests so hard? Why does antiphospholipid syndrome torture people? And it's because our assays actually only catch 1/2 of the physiology of antiphospholipid syndrome. What we really want to know when we're trying to say is that this is an autoimmune syndrome that causes your body to inappropriately activate the coagulation cascade. But our tests in the lab don't ask that question. That's not the question they ask. What the question they actually ask is, do we have antibodies that recognize the antigens that affect the coagulation cascade? But they don't actually do that second property where they recognize them and then activate the clotting cascade. It's just antigenic recognition. And we all know antigenic recognition actually sometimes even drops levels or does things in the other direction. And so our tests are very bad, is basically what I'm saying. They really only establish the necessary fact of antigenic recognition, or the fact that you've formed antibodies to things that affect the coagulation cascade. And so we have several criteria involved in the laboratory testing that tries to split it into two pieces. First of all, have we proven something that sounds consistent with autoimmunity? Autoimmunity is not a transient phenomenon. It should be persistent unless you immunosuppress someone. And that's where that stay positive for 12 weeks, which is part of the official criteria for how you diagnose it, is really important. If they don't stay positive for 12 weeks, we're probably picking up on inflammation, because there are shared antigens with things like bacteria that can turn these things positive as to why it would be the case. The second thing is what Andrew just alluded to, which is the IgG is more trustworthy. Again, sustained autoimmunity, more likely to be an IgG than an IgM. And then the third, unfortunately, because last assays fail us, is the right clinical context. So there's no amount of positive that these tests can be that define the syndrome without a clinical event, because even people with super high levels may never go on to clot. And we actually have that data from spaces like, if you take the blood of random blood donors, which, by the way, is how hematologists often get their normals for things. We take cast-offs from blood donation and see what's going on there. And if you look at blood donors, there's a set of folks walking around with these things positive that will never have anything happen in their life. And so clinical context is really important. If the patient's never clotted, you actually can't officially have antiphospholipid syndrome. Having said that, the more of these tests are positive, the more likely it is to be real. So this all three positive, it gets called triple positive. And in the context of already having shown one autoimmune thing, I'm on high alert for someone like this about being worried that they could have the real syndrome developing.
That was phenomenal teaching. Thank you so much. And if I can ask just one last question before we pass the mic back to Andrew. Before we get too deep in the case, I wanted to make sure we kind of cover our bases. And so for some of the kind of earlier learners who may be listening, I'm wondering if you could just share any advice you have on kind of if an early learner approaches thrombocytopenia, how should they be thinking of it and what should be included in their first pass workup for that?
A couple of things are really important. One, I said, is the extent. I think I've already emphasized a couple of times that super low platelet counts have a much shorter list than mildly low platelet counts. So when someone gets referred to clinic for a platelet count of 120 with no context, that is a million different things, including possibly a normal variant, which we see a lot in people from Southern Europe, actually. So the extent is there, the lower it is, the narrower your differential is. The second is the time course. If it's chronic, we think about very different things than if it's acute. And then the last is it isolated or in combination with things? So if it's part of all three cell lines being down, we're looking at the bone marrow. So I like to take those things because it helps you gather your usual suspects for what's relevant to this differential. The list for thrombocytopenia is almost every single medication, a lot of chronic conditions, splenomegaly, like it's too long. But when you think about something that's really abrupt in onset, we're almost always looking for a drug or an infection or an autoimmune process versus if it's super duper slow, I might believe someone's developing some cause of liver failure that's slowly growing their spleen or something else like that. So time course, extent of thrombocytopenia or other cytopenias with it is how I build my differential.
Phenomenal teaching. Thank you. All right, Andrew, back to you for the next aliquot.
Okay, it's going to be a lot of data coming your way. So hospital day one. So on her day of admission, she appears unwell. She appears very tired in bed. She has an ongoing mild chest discomfort that is not reproducible to palpation, and she's also starting to endure some shortness of breath. This rash that was on her legs starts to become more pronounced, and she's worried that it's spreading. So she has some initial laboratory evaluation. Her baseline creatinine is 0.9, but it's currently 3.2. She is still urinating well, and the UA shows some proteinuria and hematuria. Her CBC shows a white count of 8.4 thousand, a hemoglobin of 9.8 from a baseline of 13, and her platelet count is still in the 60s. She has an LDH that's 1100. The haptoglobin is low, and the total bilirubin is 2.3 with a direct bilirubin of 1.2. A Coombs test is negative. Her INR is normal. Her PTT is 44.2, which is what she is at baseline, and her fibrinogen is 728, and the D-dimer is 812. Her troponin is 42 and is 50 3 hours later. EKG, non-specific changes, and regarding her skin, I don't have a photo, but examination of the left leg shows some deep erythematous macules, papules, and nodules with a reticular pattern accompanied by some superficial ulcers.
All right. So again, a lot of information. And Dr. Langer, I'm curious what stands out to you about the labs and how you think you would incorporate that with the description of the rash that Andrew gave.
Yeah, so the rash is super interesting. I think the first thing I would say for everyone of every stage of learning listening is we are very worried. This is a 37-year-old woman with a non-trivial trope leak who a few weeks ago was basically fine, right? I mean, she came to clinic, but she walked into clinic and her platelet count was a little bit soft, so there was a change of therapy. So I'm very, very worried. My question in this scenario, even before hearing more about the rash, was this the natural history of her disease, or did we do this to her? By which I mean, we give so much rituximab in hematology that we sometimes forget a little bit about it. but serum sickness is a real consideration as something that can happen that can mimic a lot of this stuff. The thing that it doesn't cause that gives me a lot of pause is the trope leak. So I think I was worried about that and not so worried about that now as a consideration. I'm much more worried that this relates to the antiphospholipid labs. But I think the thing to keep in mind here is she was already a setup for a PE because she was a triple positive person. She hadn't had her clotting event. So I don't know if that's her shortness of breath. I don't know if she's having microvascular issues in her heart, because it's certainly not a coronary artery territory from what Andrew's telling us about the EKG. And she has new proteinuria, and there's a possibility that maybe she's headed in a bad direction in terms of, I don't know what to do with this LDH and the haptoglobin. Without bilirubin, I can't tell if she's starting to hemolyze. I think that PTTs are baseline and INR rules out DIC. What I'm doing right now, by the way, I should make very clear, I'm running through the catastrophic antiphospholipid criteria. That's what I'm going through systematically. So we have skin hit, probably heart hit, maybe lung hit, probably kidney hit, and we need 3 organ systems, and we've got 3 versus 4. So I'm quite worried that this person has catastrophic antiphospholipid or CAPS developing. If that's the case, we need to act fast and aggressively because that has a very high mortality rate. One of the things about CAPS that people don't always realize is that it's about 50-50. It's not exactly the perfect stat, but a gestalt sense as to whether people who get it will have had already diagnosed antiphospholipid syndrome, meaning they've had a prior clot, or that their first clotting event will be this multi-system clot. So don't take it as reassuring that she's never clotted before. She's got the antibodies, and now she's got multiple organs down.
And given kind of your suspicion for potential catastrophic APLS, how would you be thinking about kind of management at this point?
So first I want to get all the things I need to make sure I'm right, because we're going to start doing some things that are not trivial. So the first is getting a good look at the rash. I think Andrew gave a really good description, and I'm pretty worried about libido. For her, I would definitely be asking some dermatologists to give me a hand, making sure that that's the case, or rheumatology often. Either one can usually take a look at it with us and feel confident, but for this, that would be part of it. I want to look at the smear, because if there's evidence of schistocytes or other hemolysis, I might be even more worried, because that microvascular damage can generate them in that regard. So those would be kind of the high priority additional things to get cooking. But if it's the case that I'm worried about that, now we've got to really aggressively address the things that are considered are steroids, which have really dubious data. It's not that they're strong data, hard to withhold them. But there's not like really high quality data. Then we think about plasmapheresis versus IVIG, and I can pause and we can come back to why one versus the other. Rituximab, and that's part of the reason why I'm so worried, is actually part of the therapy. So if she's developing this despite getting it, I'm very worried, because that was supposed to reduce her antibody production and make this less likely to happen, even though it wasn't the reason we were giving it. So if she's only gotten 1 dose, it may just be too early to get the benefit from it. And the most important, anticoagulation. She needs it, and she needs to be given heparin IV in this case, because she just does not sound stable enough for us to anticoagulate her any other way.
All right, thank you. Andrew, back to you for the next aliquot.
So she has a pretty comprehensive multi-system evaluation over the next several days. So pretty early on, a heparin infusion is started, monitoring via anti-10A as opposed to monitoring via PTT, given the fact that her baseline PTT is prolonged. She continues to have serial troponins followed, and then she has some additional workup, notable for an echocardiogram showing diffuse wall motion abnormalities. And then around hospital day 3 and 4, she actually experiences significant rapid acceleration of her chest pain, and her blood pressure start to drop from a normal baseline with systolics around 120s to 140s to systolics around the 90s or so. So at this point, her troponin is up to 541. EKG is demonstrating global T-wave inversions. The D-dimer is up to 1,500. A VQ scan in the context of her AKI is performed with some concerns for pulmonary embolism. And a cardiac catheterization is performed given the troponins and the echocardiogram and the EKG findings. Unexpectedly shows angiographically normal coronary vessels.
Interesting. So Dr. Langer, one of the things I wanted to ask you about is, we have signs of cardiac ischemia here with the uptrending troponin, the wall motion abnormalities, but we see that the cardiac cath shows normal vessels. And I'm curious kind of how you are making sense of both of those in your mind among all the other data we got.
So that's not entirely surprising here, because the thing that makes this disease able to hit all parts of the body is that it does both small and large vessels. You can absolutely get an arterial or venous occlusion of a large vessel during an episode of CAPS, but CAPS is much more likely than the less aggressive flavor of APLS to start hitting microcirculation. And so this is a lot of small arterioles that are getting blocked off in the heart, is the way I would frame that. It also explains our EKG pattern, thinking again from a Sherlock Holmes diagnostic approach. We didn't really expect a large vessel to be occluded with that EKG pattern. So it both goes with the diagnosis as well as the data that we had. In terms of the VQ scan, I think probably a lot of people listening haven't heard one done, and I'm not sure if it was selected for one of two totally valid reasons. One reason being that her renal injury would make it riskier to give her the contrast for a CT angio. But the other is that while in general we think of a VQ scan as our second choice that we're using either because of this concern about the contrast or less radiation in the case of pregnancy or other people who have high radiation risk. But the reason that the VQ scan is sometimes our first choice test in some circumstances is that it's better at evaluating distal vasculature, remembering that the CT angio that you do for PE is specifically timed for the contrast bolus to be in the proximal circulation. We want it to be maximally sensitive for picking up that saddle PE that we expect to be our scariest thing to miss. But when you have more distal clots, it can be harder to see. And so whether that's distal, but still at a level that an angiogram could see, or here lung damage is happening at an even smaller level where no imaging is going to pick it up. I mentioned that because some of the things that we see chronically, things like chronic thromboembolic pulmonary hypertension or CTEPH, are better picked up sometimes in a VQ scan. Now, having said that, in CAPS and antiphospholipid syndrome in general, if the kidneys weren't a consideration, we'd probably still CT angio first, just to say, but there are some real advantages. I don't know which of these were the reason, but there's multiple valid reasons to see this less commonly used test selected for this individual. I'm going to pause. There's a medication we haven't mentioned yet, which now that I'm extremely worried about this patient, I would add, but I don't know if you want to go through a little bit more of the diagnostics before I mention it.
Yeah, I would definitely love to hear what you're going to say. But I think now that we have gotten so much information from Andrew, I'm curious if you wouldn't mind kind of summarizing how you are framing this case in your mind. How are you thinking about this patient?
This patient now officially meets criteria for CAPS, so I can stop hedging and say that that's the case. I think that this is a person who, unfortunately, it's possible that the rituximab tipped them over if there was a surge. And I'm realizing actually the platelet count at presentation escapes me. What was it when she came to the hospital?
Baseline 120, when she presented, it was in the 60s.
Yeah, so I don't know if the course of events was already rolling basically by the time you got here. If the rituximab was a set off, I have a hard time explaining why it would be unless it surged her platelet count up, because we've definitely have seen that. But I would say this is a patient who previously had isolated ITP and has now developed antiphospholipid, unfortunately, at first presentation as CAPS.
And then do you mind kind of clarifying again, how do you distinguish CAPS from APLS? Kind of what is the distinguishing factors there?
So it's a subset. So everybody who has CAPS has APLS. And I'm sorry that there are three. I'm sorry also for everyone listening who's not a hematologist. There are three accepted abbreviations for the exact same condition. So APS, APLS, and APLAS are all abbreviations for antiphospholipid syndrome, and by habit, the only when it's catastrophic, everybody just likes to say CAPS. So apologies for everyone who's not a hematologist and doesn't realize those are synonyms. But the distinction being made here for catastrophic is end organ damage of 3 different organs at the exact same time. So that's what makes it catastrophic. Sometimes we will allow people to get away with 2, but they are supposed to be overlapping in time too. So it's not like you had an issue before with your kidneys and now it's your heart. And the idea is really that you have microvascular occlusion happening all over your body, which is why they're supposed to be contemporaneous. Any organ in the body counts. So there are some that are more commonly affected than others, like kidney and skin are very common. Cardiac is common. Liver is really uncommon as something to be the organ hit.
Thank you for clarifying that. And before you talk about the medication, I was wondering if you could, are there any common triggers for catastrophic APLS that you've seen?
It's too uncommon as a disease to say that there's any common trigger, I would say. I don't know if there's data on any particular thing that we think of tipping people over, but one that we do know is sometimes people who have concurrent ITP, when they get treated and their platelet count rises, that's the issue. The thing we always debate in that scenario is, was it really our intervention that tipped them over, or was their ITP flare the first sign of their autoimmunity rearing its head, and it was just coincidental that we intervened on it and then they clotted around the same time? So I think that's really hard to say, but viral infections are a big trigger for autoimmune things in general, and that's certainly something that can be the case here. Pregnancy is also a tip-off thing, and they're just really about immune system regulation. I can't think of others. Andrew, I don't know. Do you want to hop in? Can you think of other times that you've seen CAPS triggered or we talk about it?
I mean, I think I would agree. There are some international registries for CAPS, but even then it's a very rare disorder, often found in the inpatient setting as opposed to in clinic where there's time to really record all this data. So hard to robustly say that there is some sort of ultimately defining trigger for these patients, unfortunately.
Got it. Yeah, makes total sense. Yeah, Dr. Langer, feel free to share what you were thinking of in terms of the other medication.
So everything I listed is the stuff that we tend to pull the trigger on right up front. But for somebody who is clotting despite being on anticoagulation, which is a little bit different than to say that somebody's damage isn't immediately resolving, but the rapidly escalating troponin makes me really worried amongst the other things that are going on. We often think about what else we can do because we said there's a lot of microvascular occlusion. And when we think about clotting in arterioles, our nephrology colleagues will definitely hop in with us in agreeing that things that start vascular damage can often recruit partners in crime. I know this sounds really opaque, but I'll clarify what I mean. So we always think as doctors about the clots being formed of clotting cascade proteins, but it's not the only thing that can block off your blood vessels or contribute to that process. And we often see that complement, this other part of our immune system, can be really prominent in that, especially when something has started to damage the endothelium. And the reason I mention nephrologists is that the glomerulus is particularly sensitive to this overlapping state where something that starts as thrombus activates complement, or complement activation activates thrombosis. And this interplay of these two things that we usually think of as silos is one is immunologic and one is thrombotic, but they really aren't physiologically. And so when you see someone with CAPS start to have worsening thrombosis, or even you could consider doing it very much up front, but is complement blockade. So eculizumab, which is an inhibitor of C5, is something that we have in our pockets, is something to add when we have people who are with antiphospholipid in general, but especially with CAPS, and especially if there's evidence that they're worsening despite immunosuppression and anticoagulation. So I would expect that this person got all of those things happening at some point during this day.
All right, Andrew, back to you. What happened next in the case, and was the patient treated with any of these?
Yeah, so hematology is finally consulted. Before formal recommendations are written in the notes, there's an early verbal recommendation to start steroids immediately. So she is started on IV methylprednisolone, 1 gram daily. Over the next 24 to 36 hours, her labs continue to worsen. Her troponin is up to 3,000. Her D-dimer is above assay. Her platelets are down to 53, and she's having some abdominal pain. A dermatology is consulted, and they agree with Dr. Langer's assessment. CT to evaluate the abdominal pain demonstrates multiple splenic infarcts bilaterally. But in the superior cuts of the CT, they also note multifocal subendocardial cardiac hypodensities. A cardiac MRI is performed concerning for microvascular ischemia. Notably, the differential on the read also said that there was a pattern that was not consistent with myocarditis. So she continues on heparin. She had already started an antiplatelet with aspirin. She's continuing steroids. And then eventually she starts IVIG and is receiving 400 milligrams per kilogram daily over a course of 5 days. There was an early consideration of the complement inhibitor eculizumab that Dr. Langer mentioned, but fortunately, after around the second day of the IVIG, the patient starts to improve, so eculizumab is deferred.
All right. And Dr. Langer, Mike, to you, what do you make of kind of this additional workup, and how would you proceed with the treatment?
So I guess I'm realizing I made the false assumption that everybody called hematology on day one. So I think for everyone listening, I would have wanted to, because you have a patient with a not normal platelet count with ITP. Forget if you think anything else about the patient's care is related to this. Forget if you didn't know. They'd never seen a rheumatologist and we didn't have the triple positive antibodies for APLS to start with. You have a patient you're starting on anticoagulation with a platelet count that's just above the threshold that we want for anticoagulation, which is 50. Above 50, we'll let people do full dose anticoagulation. And you should have a hematologist involved, because if you get into trouble with someone with ITP, remember that they're not transfusion responsive, because their problem is not in making platelets. They make them just fine. They clear them out faster, which means your usual bailout of what you might do if someone's thrombocytopenia gets worse doesn't apply, because there's no guarantee that they'll respond to transfusion. And so I mean, neither Andrew or I were involved. And obviously, when the way he presented it, it was really clear what this was going to be, which is really unfair to them. But I would just say that I was surprised to see that that was the time course they came in. And then, of course, the patient was worsening because we weren't immunosuppressing them. And anticoagulation alone is basically never sufficient for CAPS. For regular antiphospholipid, all of the time people are just on anticoagulation, and we have a debate about whether adjunctive immunosuppression with more mild agents like hydroxychloroquine is relevant. But for CAPS, it's never surprising. So seeing that with those two frontline therapies that I mentioned when I first said, like, I'm worried about CAPS, let's start steroids right away. Let's talk about plasmapheresis versus IVIG. It's much less surprising to me that somebody forewent eculizumab, because I actually did, right, in my first pass. I didn't mention it in my first tranche of meds, but I said, like, I assume this patient would be on all of those things, and they've gotten worse on day 3. So I think I would have thought about it just like the hematology consultants, where they held that for a day or two to see responsiveness in that regard. The other thing I'll mention, I've said it twice now, so I'd explain. IVIG and plasmapheresis are both trying to interfere with the antibody function as the mechanism of how this autoimmune disorder works. You really pick one or the other. The data for one versus the other has never been compared. It's too rare. And so it's really a subjective question. What I would say is plasmapheresis is a lot more complicated to administer. You have to get a central line in, you have to get the blood bank involved, you have to get them on a machine, and depending on how sick the patient is, that may be hard for them to tolerate the pheresis, it may not be. So IVIG is much easier to administer. And so it's often sometimes when we're worried, the better thing to start with, but you could easily a lot of the time choose plasmapheresis. I don't have a personal preference in that regard. But I'm really happy to see that the immunosuppression alongside the anticoagulation pulled her back. That heart imaging, by the way, very much goes with the point of a lot of microvascular damage to the heart. So I hope that she had a full recovery, because I don't think we're guaranteed to necessarily leave her without cardiomyopathy as a result of this, unfortunately.
Yeah, Andrew, could you share how the patient did?
So, very reassuringly, now that she has received every component of what we call triple therapy, which is anticoagulation, steroids, and plasma exchange or IVIG, she actually slowly recovered over the next 1 to 2 weeks. All of those scary labs, including the dimer and the troponin, all steadily downtrended. She was still, a little tired and weak on discharge. Her echocardiogram did not return entirely to normal, but she had a normal blood pressure. She was able to walk around. Luckily, no neurologic deficits. And she was transitioned from her heparin infusion to warfarin, and continued the aspirin as well. And in the outpatient setting, her ITP continued to be followed. She got some additional rituximab infusions, and luckily they did not cause any further similar hospitalizations like this one. And that's it.
Amazing presentation, Andrew. Thank you so much. And before we turn to you, Andrew, I'd love to hear your kind of reflections on what it was like caring for this patient. But one question I wanted to ask you, Dr. Langer, is, I've heard many times that kind of warfarin is the anticoagulant of choice in patients with APLS. And I'm curious if you wouldn't mind explaining that, kind of why warfarin, if there's kind of a mechanism for why that's the one that works, or if it's unknown mechanism and just kind of what research has shown.
So we have 2 clinical trials and a hypothesized mechanism. So I'll start with the hypothesized mechanism and then tell you we have no idea if I just made it up, basically, but because we have 2 clinical trials that tell us why we do it. So we didn't go overboard on how these antibodies cause problems, but tissue factor is often to blame when you see very clotty clotters. That's one of the issues in DIC. It's one of the issues with things like amniotic fluid embolism, some of the scary places. And so we know that one of the sequelae of these things, and part of why I was a little bit vague about how they work, is causing a release of tissue factor. I know nobody but me and Andrew listening probably loves the coagulation cascade. We do, we get it. It's an acquired taste. But it has a very important thing to keep in mind, which is that it activates through that part with factor 7 that comes the opposite side is that 8 and 9 hemophilia side. And so it's very possible that the fact that warfarin multi-hits, including knocking down factor 7 and thrombin as part of its mechanism, is much more protective than the things that actually act that other half of the cascade. Generally speaking, the effect of warfarin on factor 7 isn't thought to be super important overall in its function, but it's possible that's why. I find it appealing to think about. We can't really prove it. It does also relate to the one other time warfarin is still first choice, which is mechanical mitral valves, because we know that some of that tissue activation, tissue factor, and that activation from contact is an important role there too. Whether or not I'm right, more importantly, we have 2 clinical trials that have kind of the scariest version of how we know warfarin is better, which is that both of them were stopped by their data safety monitoring board, meaning it was unsafe for them to continue the trial because of a higher event rate on the 10A inhibitor, aka DOAC. So there's one trial with rivaroxaban and one trial with apixaban, and they both had to be stopped. The rivaroxaban trial specifically was for triple positive patients. So it took the highest risk tranche. And that was one of the criticisms. The answer was, okay, we really need the warfarin for the triple positives, but do we need it for everybody else? But that apixaban trial, which came out second, it actually had all comers, all different flavors of antiphospholipid syndrome, and it still had only events actually in breakthrough clotting events in the apixaban arm there. Notably, they were actually all stroke, and most of the events in the rivaroxaban trial were stroke. We don't have, I made up physiologically based, but I essentially made up the mechanism why we think it's true for clotting in general. I can't follow up with why there are arterial events. But we also know in general with antiphospholipid syndrome, your prior sites of thrombosis are the most likely to predict your future site of thrombosis, meaning arterial clotters tend to repeat arterial clots and venous clotters tend to repeat their venous clots. It's not enough to hang your hat on it, but I think it raised a lot of concerns because stroke's a pretty devastating consequence. And I think one of the things that's as a result there is that there are patients with a prior venous clot who've been on apixaban for 10 years before we had this data, who come now. I don't make them switch. I tell them about the data, but I don't make them switch. But if you have a new diagnosis, even if they're single positive and their presentation was a stroke, those patients for me have to be on warfarin. And I think What to do in this space is not totally agreed upon by hematologists because the trials were small and they were stopped early, so we don't have full data collection. But I think there really is a lot of concern. And this patient, we're not messing around with. This patient's warfarin forever. Which brings me to last kind of like public service announcement. This is a 37-year-old woman that we're putting long-term on a teratogenic agent. So, and she is a high risk for clotting. So we need to talk to her about safe contraception that is compatible, which means progesterone-only pills, IUD of any flavor, progesterone implants, but not the shots, because the Depo-Provera shot sends level high enough that some of it's converted to progesterone levels get converted to estrogen and can have actually thrombotic rates that are not so far away from estrogen containing birth control. So keeping that in mind. And I'll pause there.
Yeah, thank you so much for that explanation. Andrew, would love to pass the mic to you to hear any reflections that you have kind of from taking care of this patient, and if there are any teaching points you wanted to highlight from putting this case together.
Yeah, so firstly, congratulations to Dr. Langer on nailing the case while we were only about a quarter of the way through. I have worked with her in clinic, and she's a fantastic teacher and educator. So I was not surprised that she nailed it very early. This case was fascinating in a lot of ways because it was moving quickly, and this patient was very sick. I think the perspective that, the hematology team brings in was interesting, in that they had already been here for several days. And for us, this seems like something that would be a fairly clear-cut presentation of catastrophic antiphospholipid syndrome. But, having been on the hospital primary teams myself as an internal medicine resident, sometimes you are just so consumed with keeping the patient afloat with, one or two primary issues in front of you. It can be challenging to put all of these different pieces together and have that global perspective and make you realize that, oh, there may be an additional hematology diagnosis here that explains all of this. So I agree with Dr. Langer. When we were reviewing the patient, ideally, and it's steroids and anticoagulation, and even some of the other components of triple therapy, and even eculizumab, would have had a much earlier consideration for this presentation, just based on how sick they were initially. I think catastrophic antiphospholipid syndrome is definitely rare. I think the other teaching point to highlight is that antiphospholipid syndrome itself is also a pretty complicated diagnosis to make. So I'll note that this patient did have those antibodies that were triple positive. There's a lot of triples in this vernacular. They were positive for the lupus anticoagulant, the beta-2 glycoprotein, and the cardiolipin in that outpatient evaluation, before this admission. Just a couple points to highlight are that, if you are evaluating someone for APS, not necessarily CAP specifically, it is important to repeat those labs again after at least 12 weeks or so in the appropriate clinical context. Some laboratories will let you test that lupus anticoagulant when they're on anticoagulation or certain anticoagulants. Others are not so. So it's always helpful to double check with your hospital or local laboratory to see what kind of anticoagulants are okay for that testing. And although it wasn't specifically relevant for this case, as Dr. Langer alluded to, antiphospholipid syndrome has a lot of women's health implications as well. And APS is a diagnosis that also has another spectrum of disease called obstetric APS. So these patients may sometimes have recurrent early fetal losses or preeclampsia or placental insufficiency with severe features. They may not necessarily have a DVT or a PE or a macrovascular arterial or venous thrombosis in their lifetime. But a lot of those pregnancy challenges can be related to antiphospholipid syndrome. So that's another flavor of APS that wasn't relevant for this specific case, but is definitely a major component of antiphospholipid syndrome too.
Thank you so much for those brilliant teaching points and reflections. And Andrew, I really appreciate you putting this case together. I know it's probably a lot of work to gather all the data and present it in the way that you did. Before we end the session, Dr. Langer, I wanted to turn the mic to you to see if you had any reflections on what it was like to discuss, and if there's 2 or 3 learning points you wanted the people listening to this to take away.
Yeah, so I think there are a lot of things that people get referred to hematology for that we don't always need to be involved in. I would say that one teaching point is that things like ITP, you always want the hematologist to be aware of what's going on. May not come by every time, but just a heads up that a patient like that's in the hospital, if their platelet count's getting low, is really helpful. And I think it would have made this patient get caught sooner, because when Andrew or I look at this case, we're like, oh, right away. And it's not remotely obvious to other people. But I'm sure that he also picked up on it right away when he saw the patient in that regard, because he's sharp as a tack. Number 2, antiphospholipid antibodies are brutally annoying to interpret. I mean, you saw me try to succinctly rattle through, and it was hard to summarize all of the stuff that's there. So if you're worried about this diagnosis, it's always a time to have a hematologist involved as well. But I would also say that nobody memorizes all of the details of the prior like Sapporo criteria, which is what we used to use. Now there are these EULAR-ACR, which are the American European Rheumatology guidelines. They got even more complicated. So pull up a calculator if you're worried about it. And then the third thing is to say, we talked about a person in which these antibodies were the story, but the last thing I would just want to mention here is that there are a lot of people, as I alluded to, who have these antibodies positive and never clot and never have any pregnancy issues. And it's actually really important, as much as we don't want to miss this, that we don't over medicalize them. So if you have the antibodies around and you are not positive, most of the time the answer is leave them alone. Definitely don't put them on anticoagulation preemptively. Usually even some people are tempted to put an aspirin, and the data for that is pretty poor, actually, when we look at it. So I think it's just make sure that you interpret these complex labs. There are a lot of people who clot don't all need a hematologist. Your post-op DVT doesn't necessarily need to see a hematologist, but if you're worried about catastrophic antiphospholipid syndrome, we want to know about it.
And just as an example of this, if we reflect back on this case, this patient did have positive antibodies, but in their history, they did not have any history of venous or arterial thrombosis or any pregnancy morbidity. So they did not have a diagnosis of antiphospholipid syndrome when they first presented, and thus were not on anticoagulation.
Yeah, that's a great point. Well, thank you both so much for such an educational hour. I learned so much, and I'm sure everyone who's listening to this did as well. And we will end the session here, but just wanted to send a huge thank you to Dr. Andrew Song and Dr. Arielle Langer, and huge thank you to Vinny for scribing and Carissa for jotting down the teaching points. All right, everyone. Well, I hope you have a great rest of your night or day, wherever you're tuning in from, and we'll see you next time.
Thank you. Have a good night.
Bye.